CPR stands for cardiopulmonary resuscitation. Cardio means heart, pulmonary refers to the lungs and breathing, and resuscitation means to restore or revive. With CPR, you will be able to act positively when someone stops breathing and their heart stops. When we breathe out, the air we exhale still contains enough oxygen for it to be used by another person. By keeping the airway open and blowing air into the victim's lungs, you can provide breathing. By compressing the chest, you can cause the blood to circulate. Proper CPR provides breathing and circulation, resulting in the delivery of oxygen to the brain and other key organs of victims in cardiac arrest. Brain cells begin to die in 4 to 6 minutes after the flow of oxygenated blood stops going to the brain. Therefore, CPR must be begun immediately. Some victims of a sudden medical emergency are simply unconscious, but have good spontaneous ventilation and circulation. Others may have circulation but are not breathing. The steps you will learn here include a careful sequence to determine what the victim's needs are and to provide only those needed. It is dangerous to provide parts of the process that are not needed by the individual victim. The first step is to assess the victim's level of responsiveness to determine if he is arousable or unresponsive. The best way to do this is to tap the victim's shoulder and shout, "Are you okay?" If the victim has been injured in an accident, be careful not to shake or move him, since this can cause further damage to the spine. If you find the victim in a face-down position, you must turn him onto his back before you can assess his breathing. If he has been injured, it is particularly important to carefully move him as a unit, providing firm support to the head and neck so that it does not roll, twist, or tilt backward or forward. If the victim does not respond to your forceful tapping and loud shouts, you must quickly call for help so that an ambulance can be called while you continue to assist the victim. Even if you appear to be alone, call loudly in case someone else is nearby. Make sure that the patient is lying face up on a flat, hard surface with his arms at his sides. The next step will be to open the victim's airway. First, kneel at the victim's neck, facing across the victim. Use your hand that is closest to the top of the victim's head and apply firm pressure with your palm on the victim's forehead to tilt the head back. At the same time, place the fingers of your other hand under the bony part of the victim's lower jaw near the chin and lift the chin upward. Be careful not to close the mouth. This is called the head tilt chin lift maneuver. Keep your hands in the same position and lean forward over the victim, turning your head so that you are facing his lower body. Place your ear above his mouth and nose. Look for the chest to rise and fall. Listen for air exchange from the mouth and nose, and feel for a flow of air on your cheek from the victim's exhalation. Keep checking for 3 to 5 seconds. If the victim is breathing, simply maintain the open airway and periodically check that adequate breathing continues. If the victim is not breathing, keep your hands in the same position and with the hand on the victim's forehead, gently pinch the nose closed using your thumb and index finger. Take a deep breath, place your mouth over the victim's mouth, and make an airtight seal with your lips. Blow a full breath into the victim's mouth, take another deep breath, make the airtight seal again, and blow a second full breath into the victim. Each breath should take about 1 to 1.5 seconds. You should see the chest rise as each breath inflates the lungs and feel the air escape and see the chest drop as the victim exhales after each breath. Be sure to allow enough time between breaths for proper exhalation. If you cannot blow air easily into the victim, the head must be repositioned to open the airway. Use the thumb and fingers of the hand at the chin to grasp the lower jaw. Gently but firmly pull the jaw toward the victim's feet and then lift the jaw upward. Then seal your lips over the victim's mouth and deliver the 2 full breaths. An alternate method which may be used is the jaw thrust with head tilt. Grab the angles of the victim's lower jaw and lift with both hands, one on each side. This displaces the lower jaw upward. If the lips close, use your thumbs to pull back the lower lip to allow air to escape. Except in victims who may have a spine injury, the jaw thrust is used with a head tilt to maintain a good airway. If you still cannot blow air into the victim's lungs, you must assume that the airway is obstructed by a foreign object and go to the obstructed airway procedure. This will be discussed later. Once you have checked for responsiveness, called for help, opened the airway, and delivered the 2 full breaths, you will want to see if the victim has circulation by checking for the presence of a pulse. Continue the head tilt with one hand and locate the victim's larynx with 2 or 3 fingers of the other hand. Slide your fingers into the groove between the trachea and the muscles at the side of the neck and feel for the carotid pulse. This check should take 5 to 10 seconds and is very important, as compressing the chest of a victim whose heart is beating can cause serious injury. If a carotid pulse is present, simply continue maintaining the airway and ventilating the victim with rescue breathing at a rate of 1 breath every 5 seconds. That is 12 breaths per minute. If the victim is unresponsive, not breathing, and no carotid pulse is present, he is in cardiac arrest and needs CPR. Move down so that you are perpendicular to the victim's chest and bare his chest. If someone has responded to your call for help, have them call the local EMS emergency number to have an emergency ambulance dispatched. With the fingers of your hand closest to the patient's navel, feel the lower edge of the rib cage with your middle and index fingers. At the lower end of the breastbone or sternum is the xiphoid process. The xiphoid is an arrow-shaped extension that can easily be broken off, causing injury to the liver or spleen. Be very careful not to exert any pressure on it. Follow along the edge of the ribs to the middle of the chest. Locate the xiphoid with your middle finger. Place your index and middle fingers over the lower end of the sternum, covering the xiphoid process. This 2-finger positioning is the landmark for the placement of your other hand. It assures that your hand will be in the correct position on the lower sternum and not directly over the xiphoid. Place the heel of your other hand directly over the midline of the sternum so that it is touching the index finger of the landmark. Now remove the landmark hand and place it directly on top of the hand over the sternum so that your wrists touch. Remember, only the heel of your bottom hand should be touching the victim. Interlace your fingers and pull up on them to avoid any fingers touching the chest. Your shoulders and arms should be directly over the victim's sternum and your elbows should be locked. Use the weight of your body to drive straight down on the sternum so that you compress the chest between 1.5 and 2 inches. Do not rock on your knees or push with the muscles of the arms. The chest should be compressed for less than a second. Allow the chest to rise again to its normal position, but don't take your hands off the chest. Avoid bouncing off. You must compress and release the chest at a rate of 80 to 100 times per minute. 80 compressions per minute is the minimum rate. 100 per minute is desirable if possible. Count out loud. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12 and 13 and 14 and 15. When you have finished delivering 15 compressions, quickly reposition yourself at the victim's head. Reopen the airway and deliver 2 full breaths. Now quickly reposition yourself at the victim's side. Relocate the landmark and position your hands on the sternum as before. Deliver another set of 15 compressions, keeping your hands in position and your elbows locked. Continue compressions and ventilations at the ratio of 15 compressions to 2 ventilations for 4 cycles. Then stop and recheck for the presence of a carotid pulse. If absent, resume CPR and periodically recheck for a pulse. Once CPR is begun, you don't stop except to periodically check for a pulse. Continue CPR until an ambulance or rescue personnel arrive and are ready to take over. CPR is only terminated if spontaneous circulation returns and the patient has a carotid pulse. The patient becomes responsive, you are alone and too tired to continue, or a licensed physician declares the victim dead. Don't stop just because the EMTs arrive. Continue until they are ready to take over. They may provide CPR using a different technique and rate, since they will evolve to 2-person CPR. They will also move from manual CPR to the use of adjunct resuscitation equipment. The CPR provided by a team of healthcare professionals simply extends the critical care you have provided and increases the oxygen levels available. When the victim is a child, the same pattern is used. Determine unresponsiveness. Call for help. Open the airway. Check for breathing. Ventilate Check for a carotid pulse, and if absent, provide chest compressions. There are some changes from the exact adult method, and they will be highlighted as we review each step. First, determine unresponsiveness by shouting and gently shaking the child. As with the adult victim, the child must be positioned on his back on a firm, flat surface. If an injured child is not found on his back, be careful to turn him as a single unit so as not to cause further spine injury. It is particularly important to provide firm support of the head and neck so that the head does not roll, twist, or tilt backward or forward. Now open the airway using the head tilt chin lift or jaw thrust with head tilt technique described earlier. Remember, do not cause the mouth to close. If a neck injury is suspected, use the jaw thrust maneuver without a head tilt. Lift the jaw by pushing upward with 2 or 3 fingers under the angle of the jaw on both sides. Check for spontaneous breathing by placing your ear close to the victim's mouth and nose while looking at the child's chest. Look at the chest and abdomen for movement. Listen for air exchange and feel for the flow of exhaled air. If the child is breathing, continue to maintain the open airway. If the child is not breathing, keep holding the airway open and take a breath yourself. Pinch the nose closed with the fingers of the hand that is maintaining the head tilt. Make an airtight seal over the victim's mouth and slowly give 2 breaths. Remember that the child's lungs are smaller than an adult's, so deliver each breath only until you see the chest rise fully, and then remove your mouth and allow air to escape. If the child is very small, do not pinch the nose shut. Instead, seal with your mouth over the child's nose and mouth and deliver the ventilations. After delivering 2 slow ventilations, check for a carotid pulse with 2 or 3 fingers of the hand that has been holding the chin. Locate the Adam's apple and slide your fingers into the groove between the trachea and the neck muscles on the side closest to you. If a pulse is felt, maintain the open airway and ventilate the victim every 4 seconds. That is a rate of 15 per minute. Continue ventilations and periodically recheck the pulse. If a pulse is not found, the victim needs CPR. Maintain the head tilt by keeping the hand on the child's forehead in place. Reposition yourself at the victim's side. If someone has responded to your call for help, have them call the local EMS telephone number to summon the emergency ambulance. Using your hand closest to the child's feet, find the lower margin of the child's rib cage. Slide your fingers along the edge of the ribs until you locate the notch where the ribs and sternum meet. Locate the xiphoid with your ring finger. Place your middle and index fingers over the xiphoid at the lower end of the sternum. This is the same landmark position that you use for adult victims. Look carefully at the location of your fingers on the child's chest, as this will usually be the only time that you actually feel for the correct landmark position. Now lift your fingers from the sternum and place the heel of the same hand on the sternum so that it is alongside the place just occupied by your index finger and not over the xiphoid process. The axis of the heel of the hand must be in line with the midline of the sternum. This landmarking technique represents a current change. While maintaining head tilt with the hand closest to the child's head, compress the chest with your other hand to a depth of 1 to 1.5 inches at a rate of 80 to 100 times per minute. The fingers of the hand used for compressions must not come in contact with the ribs. Unlike with an adult, the ratio of compressions and ventilations for a child should be 5 compressions to 1 ventilation. Remember that the hand closest to the child's head remains on the forehead to maintain the head tilt. After every 5th compression, the hand doing compressions is used to reestablish the chin lift, and 1 slow, full breath is given. The hand doing the chin lift is then repositioned back on the sternum by visualizing the position only. Then another set of 5 compressions is delivered, and so on. The procedure outlined here, namely head tilt with your hand on the forehead and moving your other hand back and forth at the chin for ventilations and on the sternum for compressions without landmarking except the first time, is a change from the original 1986 standards. This change has been found necessary in order to be able to provide compressions at a rate of between 80 and 100 compressions per minute. It is the current standard from the National American Heart Association's Pediatric Working Group. Recheck the pulse after the first 10 cycles of CPR and every few minutes thereafter. Body size rather than age is the key factor in determining whether to use the adult or child procedure. Children with an adult body size, namely that greater than the size of an average 8-year-old, should be resuscitated as you would an adult. When the victim is an infant, tap or gently shake him to determine unresponsiveness. If the victim is unresponsive or is having trouble breathing, call for help. Position the infant on his back on a flat, firm surface. If you suspect any injury, turn the infant as a unit. Open the airway with the chin lift head tilt maneuver. The head should be just slightly tilted. Do not tilt the head back significantly as you would in an adult. Never allow the infant's head to hang unsupported over the edge of the surface on which he is lying, as this is dangerous and can easily result in cervical injury. Make sure that the mouth remains open. The jaw thrust maneuver without head tilt should be used if spinal injury is suspected. Look, listen, and feel for signs of breathing. If breathing is present, maintain the airway and monitor breathing until the EMTs arrive. If spontaneous breathing is not present, while maintaining chin lift head tilt, take a breath and make an airtight seal over the infant's mouth and nose with your mouth. Deliver 2 slow, small breaths of 1 to 1.5 seconds each, stopping each breath when you see that the chest is risen. Then remove your mouth, allowing air to be exhaled. In an infant under 1 year of age, the short, chubby neck makes it very difficult to feel the carotid pulse. Instead, the brachial pulse, found in the arm, is used. Maintain the head tilt with your hand on the infant's forehead. With your other hand, elevate one arm over the infant's head, and with your thumb on the outside of the infant's upper arm, use the index and middle fingers to press gently on the inside of the upper arm as shown. If a pulse is present, continue ventilations every 3 seconds or at about 20 per minute. If someone came when you called for help, have them call the local EMS number to summon the emergency ambulance. If no pulse is felt, chest compressions will be needed. The landmark position is different for an infant. While maintaining head tilt, imagine a line between the nipples across the sternum. Using the hand closest to the infant's feet, place your index finger just under the imaginary line and on the midline of the sternum. Lower your middle and ring fingers into place next to the index finger, and then lift the landmarking index finger off the chest. Simply stated, chest compressions are done on an infant with just 2 or 3 fingers, which are placed on the midline of the sternum, 1 finger's width below the imaginary line between the nipples. Continue to maintain head tilt with the hand closest to the infant's head while performing chest compressions with the other hand. Begin compressions using the 2 fingers at a rate of at least 100 per minute. Compress vertically, straight down between 1/2 to 1 inch. Allow the sternum to rise to its normal position after each compression. Do not lift your fingers off the chest between compressions or between cycles. The rate of compressions to ventilations, as with a child, is 5 to 1, with a pause after each 5th compression to deliver the next ventilation. In order to perform compressions at a rate of 100 per minute, the head tilt is maintained at all times in the cycle with the hand closest to the infant's head remaining on the forehead and the fingers of the other hand that is placed on the sternum also remaining in place. The rescuer provides the breath and then the compressions without moving his hands from their location. This change from the original 1986 standard has been found necessary by the Pediatric Working Group of the American Heart Association in order to provide enough compressions per minute. Carefully watch the chest during each ventilation to make sure that it rises. In most cases, the airway will remain open with head tilt alone. However, if the chest does not rise and an open airway cannot be maintained, use the hand which was on the chest to perform a chin lift before each ventilation. In such cases, a compromise has to be made on the rate of compressions. Do 10 cycles of compressions and ventilations, then recheck the pulse and respiration. If the infant is unresponsive and no spontaneous respiration and brachial pulse are present, continue CPR, rechecking for a pulse every few minutes. When an airway obstruction is caused by a foreign object, such as a piece of steak lodged in the throat, different techniques are first used to expel this object out of the airway. The head tilt chin lift, jaw thrust with head tilt, or in an injured victim, the jaw thrust without head tilt airway maneuvers Open the airway and result in pulling the limp tongue forward so that it does not obstruct the airway. The limp tongue falling back over the airway is the most common cause of airway obstruction. The key to determining airway obstruction from a foreign object is either that someone witnessed the event or that the situation in which the choking victim is found strongly suggests that probability, or that in the absence of these, the airway maneuvers fail after several attempts to provide a clear airway. Early recognition of foreign body airway obstruction is the key to successful management. With a partial obstruction, when the conscious victim still has a good air exchange, encourage the victim to keep trying to clear the obstruction himself by coughing. Stay with the victim. The universal distress signal for an obstructed airway is the victim clutching his own throat as shown. This signal was selected because it is a natural, instinctive movement which people who are choking make, whether they have learned it in a CPR course or not. When you see this, or when you see someone apparently choking, quickly approach them and ask, "Are you choking?" If the victim can reply or is coughing forcefully, he still has good air exchange. Encourage his coughing, but do not interfere. If the victim is unable to answer, or if the coughing becomes ineffective and he cannot cough forcefully, the victim has poor or no air exchange. Airway obstruction may also be associated with no sounds or with a high-pitched crowing sound, an exaggerated movement of the chest and abdomen, which are not accompanied by an air exchange at the mouth and nose. If there is no air exchange or poor air exchange, the victim must be assumed to be obstructed. Stand behind the victim and wrap your arms around him. With one hand, feel for the xiphoid and the navel. Make a fist with the other hand and turn it so that the thumb side of the fist is on the midline of the victim's abdomen, well below the xiphoid, but above the navel. Grasp your fist with your other hand. Press your fist into the victim's abdomen with a quick inward and upward thrust, then relax the pressure. Each new thrust should be a separate and distinct movement. Make sure that your hands remain in the correct position. Continue to deliver abdominal thrusts until the foreign body is expelled or the victim becomes unconscious. It is important to brace yourself and the victim. If the obstruction persists, the victim will become unconscious and sink to the floor. Being prepared can help avoid injury to you and the victim. If the victim becomes unconscious, help to support them by sliding them down your leg to the floor. Position the victim on his back, face up with his arms at his side. Call for help and have someone call for the emergency ambulance. Open the victim's mouth by lifting the lower jaw. Place your thumb on the tongue and wrap your fingers around the jaw. Lift the jaw to open the mouth. This is called the tongue jaw lift. Use the index finger of the other hand to reach along the inside of the cheek towards the base of the tongue. Scrape across the back of the victim's throat and clear the debris out the other side of the mouth. Use a hooking action to dislodge any foreign body and maneuver it into the mouth so that it can be removed. After the finger sweep, open the victim's airway and attempt rescue breathing. If the airway remains blocked, straddle the victim's thighs. Place the heel of one hand against the victim's abdomen, in the midline, above the navel, and well below the xiphoid. Place your other hand directly on top of the first. Deliver quick thrusts by pressing your hands into the abdomen and thrusting up towards the patient's head. Deliver 8 to 10 thrusts. Using the tongue jaw lift, open the mouth. Recheck the victim's mouth for any foreign objects that may have been expelled into the mouth and use the finger sweep to remove them. Reopen the airway and again attempt to ventilate the victim. If ventilations are successful, check for a pulse. If present, continue rescue breathing. If no carotid pulse is present, continue CPR. Deliver ventilations and chest compressions as needed until the EMTs arrive and take over. If ventilations are not successful, repeat the sequence of abdominal thrust, tongue jaw lift, finger sweep, and attempted ventilations. Continue this sequence until the object is expelled and ventilations can be delivered, or the EMTs arrive and take over. When an adult victim is found lying down, check for unresponsiveness by tapping or gently shaking the person and shouting, "Are you okay?" If the victim is unresponsive, call for help so that an ambulance can be summoned. Position the victim on his back. Be especially careful in moving him if there is any reason to suspect injury to the neck or spine. Open the victim's airway using the techniques described earlier. Look, listen, and feel for air exchange. This check should take 3 to 5 seconds. If there is no sign of air exchange, attempt to deliver 2 slow breaths. If ventilations are unsuccessful, reposition the head, extend the jaw, and again attempt to ventilate. Prepare to deliver abdominal thrusts by straddling the victim and placing your hands in the correct position on the abdomen, well below the xiphoid and above the navel. Deliver 8 to 10 abdominal thrusts. Check for foreign objects in the victim's mouth. Use the tongue jaw lift and perform the finger sweep maneuver. Remove any foreign objects that you find. Reopen the victim's airway and again attempt to ventilate. If ventilations are unsuccessful, repeat the sequence of abdominal thrusts, tongue jaw lift, finger sweep, and attempted ventilations until the object is expelled or EMS personnel arrive and are ready to take over. In the case of a pregnant victim, a victim with abdominal injuries, or in a grossly obese victim, abdominal thrusts should not be used. Instead, in such cases, chest thrusts should be delivered. In a conscious victim, stand behind the victim as before. Slide your arms just under the victim's arms. Place the thumb side of your fist on the middle sternum. Grasp it with your other hand and press with quick backward thrusts. Unlike abdominal thrusts, the pull is straight back without any upward motion. If the victim is lying down, the thrusts are delivered in the same manner as CPR. Deliver each thrust slowly and distinctly instead of rapidly as with normal compressions. The obstructed airway procedure for children is like that for adults. Some differences, however, do exist. This procedure should be initiated in a conscious child only if the airway obstruction is due to a witnessed or strongly suspected aspiration and if respiratory difficulty is increasing and the cough is ineffective. If the obstruction is caused by airway swelling such as epiglottitis or croup, these procedures may be harmful. In such cases, EMS should be summoned and the child should be rushed to the nearest advanced life support facility by emergency ambulance. The child should be maintained in the position of maximum comfort, which allows for the easiest breathing. If a conscious child is suspected of having an airway obstruction from a foreign object, first ask, "Are you choking?" If the response indicates no air exchange or poor air exchange, stand behind the victim. Wrap your arms around the victim's waist with one hand made into a fist. Locate the correct position in the midline of the body, above the navel, and well below the xiphoid tip. As in an adult, place the thumb side of your fist on the abdomen. Wrap your other hand around the fist and deliver quick upward abdominal thrusts until the foreign object is expelled or the victim becomes unconscious. Be careful that your hands remain in the correct position for each thrust. If the victim becomes unconscious, lower him to the floor and position him on his back with his arms at his side. Call for help to activate the EMS system and summon an emergency ambulance. Perform the tongue jaw lift and look into the mouth. If the object is visible, remove it. Do not perform a blind mouth sweep in children. Kneel astride the child or at his feet. Place the heel of one hand on the victim's abdomen, in the midline above the navel and well below the xiphoid tip. Place your other hand on top of the first. Press into the abdomen with quick upward thrusts. Deliver 6 to 10 abdominal thrusts. Be careful to keep your hands in the correct position. Use the tongue jaw lift maneuver to open the victim's mouth. Look for any foreign objects and remove any that you find. Remember, do not do a blind finger sweep in a child. With the victim's airway held open, attempt to deliver 2 full ventilations. If the ventilations are not successful, repeat the sequence of 6 to 10 abdominal thrusts, followed by the tongue jaw lift and looking in the mouth for foreign objects, followed by then opening the airway and again attempting to ventilate. Continue this until you are successful in dislodging the object or EMS personnel arrive and are ready to take over. When you come upon a child who appears to be unconscious, determine responsiveness by tapping and a loud shout. If the victim is unresponsive, call for help. Position the victim on his back. Open the victim's airway using the head tilt chin lift or jaw thrust with head tilt maneuver. Look, listen, and feel for air being exchanged. This check should take 3 to 5 seconds. If the victim is not breathing, pinch the victim's nose shut, seal your mouth over the victim's mouth, and attempt to ventilate. If the ventilation is unsuccessful, reposition the head and jaw and again attempt to ventilate. If ventilations are still unsuccessful, position yourself astride the victim or at his feet. Locate the proper position on the midline of the abdomen, above the navel but well below the xiphoid tip. Place the heel of one hand on the abdomen. Place the second hand directly on top of the first and perform 6 to 10 quick upward abdominal thrusts. Using the tongue jaw lift, reopen the victim's mouth and look for any foreign bodies. Remove any that you see. Remember, do not do the blind mouth sweep in children or infants. Next, open the airway and attempt to ventilate the victim. If you are unsuccessful, repeat the sequence of abdominal thrusts, tongue jaw lift, looking into the mouth, attempting ventilations, and so on, until you are successful in clearing the object or EMS personnel arrive and take over. Airway obstruction in an infant calls for use of different techniques than those used for an adult or child. This procedure should only be initiated if the airway obstruction is due to a witnessed or strongly suspected aspiration, and if respiratory difficulty is increasing and the cough is ineffective. If the obstruction is caused by airway swelling due to infections such as epiglottitis or croup, these procedures may be harmful. In such cases, the infant should be rushed by emergency ambulance to the nearest advanced life support facility. When an infant is obstructed and having difficulty breathing, or cannot breathe, support the head and neck and place the victim face down